Hello, everyone, and thank you for your patience as we got started. A little bit of technical difficulty, even in this day where we're getting used to only seeing each other by Zoom and virtual platforms. It can still happen, so thank you for your patience. For anyone who didn't already get the information, if you wish to have the instructions in French, they're on the screen right now. You can call into that number. And Dr. Salopek and I will be speaking in English, which is, I think, our favorite language. I'm sure I can speak for both of us, or the only one I can speak anyway. So we'll get moving in a moment. If I could just remind everyone on the French line to please mute your phones. And if we have any audio trouble at any point, I will just pop in and interrupt us. So without further ado, I will get rolling here. Thank you for joining us and again for your patience while we get started. My name is Natalie Richardson. I am a melanoma survivor and the Managing Director at Save Your Skin Foundation. I welcome you to today's webinar presentation titled Melanoma and Non-Melanoma Skin Cancers from A to Z. As you may know, May is Melanoma and Skin Cancer Awareness Month. So we find it imperative to remind everyone of the importance of sun safety as summer approaches. As the COVID-19 pandemic continues to force many Canadians to stay at home, people are spending more time than usual outdoors without understanding the risks associated with sun exposure. Skin cancer is the most common of all cancers. There are more new cases of skin cancer each year than the number of breast, prostate, lung, and colon cancers combined. In 2020, over 80,000 Canadians were diagnosed with skin cancers, and over 1,300 lost their lives to melanoma. On top of this, recent survey data shows that 1 in 4 Canadians are unaware that spending more time in the sun increases their risk of skin cancer, and more than half of Canadians do not realize a small amount of sun exposure without protection can lead to melanoma. Today's webinar will do a deep dive into this issue and help educate the general public about the dangers of UV exposure, and it will also address what options patients and their families have if they are diagnosed with any form of skin cancer. We will learn about primary and metastatic basal cell carcinoma, squamous cell carcinoma, and the more rare Merkel cell carcinoma. We will also hear about treatments for melanoma, including surgical options and immunotherapy and targeted therapy for metastasis. To give us this comprehensive overview, we are honored to welcome dermatologist Dr. Tom Salopek, who's a professor at Department of Medicine and Division of Dermatology at the University of Alberta in Edmonton, Canada. Dr. Salopek is a member of the Save Your Skin Foundation Medical Advisory Board and has long been an active supporter of the Alberta Society for Melanoma, treating skin cancer patients from all over Alberta. I'm happy to say I've seen Dr. Salopek speak several times on topics related to dermatology and oncology in a few cities across Canada, and I'd like to add he and I first met by chance in Australia at the 2017 Society for Melanoma Research Congress. Dr. Salopek, I will hand the stage over to you in a moment, but I would like to say I and all of us at Save Your Skin and Alberta Society of Melanoma appreciate the opportunity to work with you on this educational resource and all that you do for patients. We'll get started on the presentations in a moment, but first a few logistics. All participants in the audience for today's webinar will be in listen-only mode for the duration of the session. There will be a question and answer portion at the end of the presentation if we have time. You will see the right-hand side of your screen, you will see on the right-hand side of your screen the option to type in a question under the word questions. Please feel free to ask your questions throughout the presentation. We will do our best to answer them in the last segment. If there are any questions that do not get an immediate answer, we will contact you afterward with a reply and any discussion you wish to have after the webinar. This session will be recorded and will be available for viewing in English and in French on the Save Your Skin Foundation website and YouTube channel. We wish to thank our partners for their generous support of this webinar. We are pleased to collaborate with Alberta Society of Melanoma and the Quebec Cancer Foundation, among others, to support skin cancer patients across Canada. We also wish to acknowledge the funding sponsor, Roche-Posay, for their efforts in increasing sun safety and skin cancer awareness, as well as their work to improve the quality of life for cancer patients who may experience dermatological side effects from their treatments. For more information, please visit their website, Caring for Skin Through Cancer, the link for which I will show a little bit later. Thank you, Roche-Posay. And thank you everyone for joining us. We'll now begin the presentation. Dr. Salopek, just bear with me one moment. I'm going to hand the controls over to you, and I will stop taking up time as you are the star here. Just handing it over to you so that your slides will show.
So is everyone seeing my slide? Natalie?
Yes, I can see your slide. Yes, sir. That's perfect. Thank you very much. I will put myself on.
Everything's good.
Great.
As Natalie mentioned, we were having a panic mode there. There's a lot of technical glitches, and unfortunately, I'm speaking through a phone rather than through the computer audio. So hopefully, it doesn't break up, or there's no problems with the presentation. I'm delighted to be here this afternoon to present to you. Natalie had a very ambitious objectives for me, and I've listed them here. And we actually have almost 200 slides. I hope we'll go through them all. But if not, I'd be more than welcome to do round two. Frequently, what I do with my residents and students, we do a round two if there is a need. It's a very ambitious objective today, and there's so much ground to cover. In fact, each one of these sessions, each one of those topics, the melanoma, basal, squamous cell, Merkel cell, could fill an hour and a half, in fact, hours worth of presentations. So what I want to do is just review some of the statistics. Then what are the warning signs? What's going to allow you to make a diagnosis of skin cancer, and then hopefully bring yourself to your doctor. Review the various skin cancers. There's no way we can cover them thoroughly. Two that I cover the most probably in detail are melanoma, obviously, and then Merkel cell carcinoma. And then we'll be talking about some of the treatments for these tumors as we go along as well. So in terms of Canadian statistics, up until recently, it was very hard to actually get Canadian statistics. As Natalie mentioned, cancer is a very prevalent problem in Canadian society. Up to a third of Canadians may die of cancer. The more recent statistic from 2020 suggests that 1 in 2 Canadians will get some form of cancer during their lifetime, which includes skin cancers as well as non-skin cancers, and then 1 in 4 will actually die from their cancer. So those are very stark statistics. In terms of cancers that are out there, melanoma is the 8th most common malignancy diagnosed on an annual basis. As you can see, almost 250,000 people are diagnosed with cancer in Canada yearly, and 8,000 of those are from melanoma. When we look at the mortality from melanoma, unfortunately, it is still a fatal disease despite the progress that we've been making in the last 5 to 10 years. Approximately 1,300 people will die from this cancer on a yearly basis in Canada based on 2020 statistics, which translates to about 3 to 4 people dying every day from melanoma in Canada. So that's a very disappointing statistic and something that we need to work on. Now, based on 2010 estimates, we know that the average Canadian male has about a 1 in 57 chance of developing melanoma in his lifetime, and has about a 1 in 227 chance of dying from this malignancy. Women, the frequency of melanoma is a little bit less. It's about 1 in 74, and the probability of dying is about 1 in 456. One of my colleagues from McGill recently published Stats Canada data regarding incidence and mortality from melanoma in a Canadian population. Up until this publication, there was in fact no coherent publications available. What this figure shows is that over a 20-year span, there's been a steady increase in melanoma, both in men and women. So hopefully you can see my mouse here. You can see it's been steadily rising. We're now, for both genders, having about an incidence rate of 15 per 100,000. So generally, when we talk about the frequency of cancers in a population, we use the word incidence rate, and it's mostly per 100,000 persons. So about 15 per 100,000 will develop melanoma in both sexes. You can see it's slightly higher for males than it is in women. Unfortunately, Stats Canada's data stops at 210. I've had access to their data, and I know that they do not provide data for more recent statistics, but that's the best we have right now is 2010. Mortality rate has been slowly increasing as well, but not as steep as the curve as you see with the incidence of melanoma. And the thing that's interesting is it's almost certain this statistic will not still be the case because of recent advances in therapy. There are now treatments that are curing melanoma patients. In the past, we were very loath to use that term cure, but we now have patients who are now 5, 10, almost 15 years post immunotherapy, and they are disease-free. So, for lack of a better word, we have to assume that they are, in fact, cured of their cancer. One of the other things that came out of that study was that there's quite a disparity in terms of the frequency of cancer across the country. British Columbia and the Maritimes, particularly New Brunswick, PEI, and Nova Scotia, have some of the highest incidence rates, bordering close to 20 per 100,000, whereas Quebec has one of the lowest. Now, the issue with Quebec, not to single them out per se, but since I've had access to the Stats Canada data, I'm aware of it, that there was actually problems with their registry in the 1990s and 2000s, early 2000s. And so the full picture in Quebec is not known. It's not likely that the incidence of melanoma is lower in Quebec, but there was, again, issues with just ascertaining and including these people in the registry, which accounts for the statistics that Stats Canada reports. As I mentioned, we've actually done similar work, and we showed, using the same data from 1992 to 2010, that the incidence has been increasing, and that it is more prevalent in males than females. That's why I want to show this graph and just highlight worldwide. You'll hear that recurrent statistic that melanoma is more frequent in men, and you'll see in a moment why that's the case. So in men, it peaked in 2009 at almost 15, women at about 12 per 100,000. What's interesting that we found is that, yes, that's true. The blue line is males, and today's melanoma is more prevalent in males than it is in females, but it only accounts for people after the age of about 50. If you blow up that same image, you'll see that, in fact, women are almost twice as likely to have melanoma between the ages of 15 and 47. So there's something that's happening that's unique to the female gender that predisposes them to melanoma. In addition to that, so there's something that's going on that raises the possibility maybe it's hormones. Coincidentally, those numbers, 15 to 45, coincides with when women enter into puberty, start their menarche, and end their periods in their 40s at menopause. Interestingly as well, if you go back to that figure, you can see that the increase in women is, for the most part, linear. It's a straight line. Whereas men, it's this exponential, this curvilinear approach, and it really takes off by the time they're in their 50s. In addition to this increased prevalence during those childbearing years, we also found that there's significant differences between men and women in terms of where the melanoma is located, the subtypes of melanoma that they develop, and that these changes remain stable over the past 20 years. So it's something that's inherent. It's not an environmental issue that's necessarily changing. It's inherent to features that make up the genders. In terms of non-melanoma skin cancer, unfortunately, we don't have a lot of statistics in Canada. In fact, this review article just highlights the fact that we do not have national statistics. Natalie did quote a number of about 80,000 skin cancers, but it's very hard to actually access Stats Canada data because not all provinces record non-melanoma skin cancer in their registries. So this paper by one of my colleagues, Dr. Abbas, looked at the 4 jurisdictions in Canada that have actually published their data. That included work that we had done in Alberta, but also Manitoba, New Brunswick, and British Columbia. Those are the only 4 provinces that have actually published their statistics with regards to non-melanoma skin cancer. I'll just focus on Edmonton or Alberta for the time being. That's the red line here. So in Alberta, we did see a progressive increase in incidence of non-melanoma skin cancer during our study period, which was from 1990 to 2007. But it seemed to peak at about 2000. If anything, it was either stable, flatlined, or even was decreasing, whereas other jurisdictions have shown a progressive increase. So British Columbia is the green, and the blue here is Manitoba. I think the purple is New Brunswick, New Brunswick. So New Brunswick also saw kind of a stabilization for basal carcinoma in men, whereas women, it seemed to be still increasing in their population. For squamous cell carcinoma, we found the same in that there was a progressive increase in incidence of squamous carcinoma, but then it peaked by about 2,000, became level for men. In women, it showed a continued increase during our study period. The purple here, New Brunswick, has been pretty flatlined with regards to non-melanoma skin cancer, or sorry, squamous carcinoma in men, whereas in women, it still tends to increase, as does New Brunswick and British Columbia. The only other cancer that we have statistics for, and this is unpublished, we did a study, and the reason we never published it is because Stats Canada does not have data on Ontario. It has statistics for Merkel cell carcinoma for all of the country except for Ontario. So we were a little bit reluctant to say this is a reflection of Canada when we're missing the most populous province. But using the data that we have for the 9 provinces and the 3 territories, we calculated that the age-adjusted incidence for Merkel carcinoma is 2.2 per million. And I want to stress that it's using million just because it's so rare. This tumor is so rare that if you were to quote it in for normal standard 100,000, it'd be a fraction of a person, so it'd be 0.2 per 100,000. It is more common in men than in females, as the overall incidence shows. It's 2.7 per million in men, whereas in women it's only 1.8. We know the incidence is increasing over our study period. We looked at this over a 20-year span, and this is not unique to Canada. This is actually seen worldwide, where the incidence of Merkel cell carcinoma has been steadily increasing. And it's thought to be in part due to better ascertainment by the registries. The registries are better in collecting the data, and there's also better diagnostic techniques. These are often called other tumors as well. I just want to contrast with the U.S. I try to avoid using U.S. data because it's not necessarily reflective of Canada, but they are more contemporary than ours. And this paper, just hot off the press, as Lydia just published recently, shows that the mortality rate for melanoma is actually dropping. So for decades, we used to always say the melanoma mortality rate is increasing. It's increasing ever so slightly, but it's still consistently increasing. But here it's actually showing that it's decreasing. And that decrease, if you kind of look around here about 2009, 2011, is actually when immunotherapy started to take a foothold. So that's when ipilimumab was first launched. And you can see that's probably contributing to the decrease of mortality. In terms of the other non-melanoma skin cancers, squamous carcinoma and basal carcinoma, they've been flatlined in the U.S. over the last 15 years. So there's no increase in incidence. So they've probably peaked out. It's understandable why they've probably peaked out. We'll refer that for another day. So I can't stress enough how important it is for early detection with all these tumors. Not only does it, improve and make it easier for the physician to remove the tumor, but also improves the probability that you will survive your cancer. The latter, particularly with regards to melanoma and Merkel cell carcinoma. As you'll hear, it's not common for people to die of squamous carcinoma, and even more so for basal carcinoma, but it does happen. But the other two do have a very significant potential mortality rate, and it's strongly linked with the stage at which it's detected. The earlier the stage of detection, the better the outlook. If it's detected at advanced stage, and the outlook is not so good. Now, early detection, for the most part, hinges upon doing a total body skin examination. When we refer to patients, we refer to this self-skin examination, just like self-breast examination, and we encourage the public to do it. It doesn't take very much, but we also encourage physicians to do that, and unfortunately, it's not, a routine part of a family doctor's visit, or even a visit with a dermatologist. Most dermatologists will not offer a full skin exam. It's something that you'll have to request, or they will do one on the basis of some other concern that they have. We know that doing a full skin exam is not a very onerous task for the physician. This study from about 10 years ago showed that it only takes another minute or so to do a full skin exam. So it's not too demanding on the physicians to do one. And I mean, when I lecture, I encourage family doctors to be part of the solution and to be proactive in doing total skin examinations. Now, in terms of what to watch for, the skin changes that are being described for skin cancer were designed with the lay public in mind. Physicians routinely use them as part of their strategy to determine whether a lesion they're seeing is suspicious or not, but in fact it was designed with you in mind, and that would help you recognize a lesion that should prompt you to see your doctor or your dermatologist. So here are some of the signs that have been published. The most longest present rule is the ABCDE rule. There's the ugly duckling sign, also known as one of these things is not like the others. The 7 S's, which I have been championing, is something that I coined. The SCAN rule, which the Australians have come up with, and then this rule for Merkel cell carcinoma specifically. The top 3 ABC, ugly duckling, 7 S's are melanoma-specific warning signs. SCAN is in fact an acronym that is non-melanoma specific. It's for all types of skin cancer, including Merkel cell carcinoma. And AEIOU is specific for Merkel cell carcinoma. So the classic rule, the ABCD rule: A for asymmetry, border irregularity, where the border may be sharp or just jagged, irregular, notched. Color variation in general, we're talking about more than 2 colors. An arbitrary 6 millimeters has been set as the kind of critical diameter that you should be worried about, but if it's smaller than that, it still could be melanoma. In that case, you'd be worried more about new or evolving. So if you have an evolving lesion, then you'd obviously be worried about it. So this in schematic formation just shows you the asymmetry. Asymmetry, generally referred to as when you put a line through a spot, one half is not like the other. This B shows very nicely the border irregularity and the fact that some areas aren't as sharp as the others. Here, color variation is what we definitely focus on. It could be jet black, and just a uniform black would also be very worrisome, like this D slide here. But generally, more than 2 colors is required before we're a little bit anxious about a lesion. And in this picture just shows nicely this E, where you have a spot that's been present, and then a year later, it is almost 3 times as big. The ugly duckling sign is a very useful sign to help you spot the worrisome lesion when you do a self-skin examination. And it's that lesion that sticks out relative to the other. I mean, it just doesn't seem to be in keeping with those. And the Sesame Street song of one of these things is not like the others nicely captures what you're looking for. So you're looking at your skin, and you'll notice that one of your moles or spots or whatever just doesn't seem to fit with the others, and that'll be the clue that it's probably something you should have assessed by a physician. So, and this is a good example of that. I'm sure I usually make this interactive, but if we were to poll the audience and say which one of these spots doesn't seem to be in keeping with the others, everyone would recognize this lesion on the shoulder there. And when you blow that up, you see definitely it's got all the ABCDs that indicate that this is a worrisome lesion. And then in the end, this proved to be an early melanoma, a melanoma in situ, which is potentially curable cancer. So we've coined the 7 S's of melanoma, and it kind of mirrors those others, just using the letter S. So size, specifically a change in size, a change in shape, change in shades of color, there's a change in the surface, specifically bleeding, oozing, crusting. Now, granted, this is a more advanced stage, but this is what brings you into the office, so be it. If you're starting to know the symptoms, that it's becoming itchy or tender or painful, this might be the first clue that this is a potentially worrisome spot. If there's satellites, which are these breakaway lesions, and lastly, stability, in fact, is the opposite. If you see a stable lesion, that's a sign that that's very likely a benign lesion, whereas if it's changing again, that's a sign of a worrisome lesion. The Australians pioneered SCAN. This has been around for about 5 years. It is non-melanoma specific. It's for all forms of skin cancer, and every time patients come up to see us, we routinely advise them. Now, the acronym serves 2 purposes. It highlights that you have to do self-skin exams, hence the word scan your skin, and then each letter highlights what are the worrisome features. S is for a sore, meaning sore can mean 2 things, meaning a spot that doesn't want to heal, or it also means a spot that's bothersome. It's itchy, it's painful, it's bleeding, etc. C is for changing. Again, getting back to that E of A, B, C, D, E. So change is a very, very striking feature when it comes to lesions on your skin. If you think it looks abnormal, it's the ugly duckling, it's one of these things not like the others, then obviously you should be coming in to have that assessed. And lastly, if it's new. Now, when do we say new is worrisome? You know, you can develop moles up into your 40s, but after the age of 40, it's quite uncommon to develop a new mole. The spot you're developing is probably either an age spot, a seborrheic keratosis, or something more sinister. So anything new after the age of 40 should be viewed with some suspicion. And if you're uncertain, then have someone look at it. In terms of the last malignancy, that is Merkel Carcinoma, there is this mnemonic. It's not an acronym, it's mnemonic. So SCAN is a mnemonic or an acronym, whereas AIEOU is the features that allow a physician, and there's no reason why a patient can't use this as well for assuming if there's something bad going on. You know, A is for asymptomatic, meaning it has no symptoms, which is the most common complaint patients will tell us when they present to us with a Merkel Carcinoma, that there was nothing bothersome about it. E is for an expanding lesion, meaning you notice that it's expanding rapidly, and we're talking in the order of weeks to several months. We're not talking over years. I is for immunosuppressed. If you have something wrong with your immune system because you're on medications that are suppressing your immune system, because maybe you have leukemia or you're a transplant patient. So those are the features that indicate you're immunosuppressed. O is for older than 50 years of age, and U is for ultraviolet light, meaning it tends to occur in sun-exposed areas. Does that mean you're not going to get a Merkel carcinoma on your buttock? No, it doesn't mean that, absolutely. But a lesion that's in sun-exposed areas, which for the most part is the head and neck area and your upper limbs, that accounts for the great majority, over 80% of melanomas will be in that location. So those are the warning signs. Now I'm just going to do, as to use Natalie's term, a deep dive into melanoma. Melanoma is something that constitutes the great majority of my practice. Probably 60–70% of what I do is melanoma. So, and it's obviously the tumor that is most well known and potentially the most serious of the malignancies that we're going to be talking about today. So, what is melanoma? Some of you have melanoma, so you know what it is in terms of cancer, but it's actually a cancer of the melanocytes. And cell for cell, it's considered one of the most aggressive tumors out there because of its propensity to metastasize, and when it does, it can be fatal. Fortunately, with new treatments, that will not always be the case. So in Canada, just as simple numbers, what I tell my residents, we're trying to remember what's the probability of you getting melanoma in a male. It's about 1 in 50. Women, it's 1 in 75. Now, this sounds like a big number, but just to put it in perspective, the chance of women getting breast cancer is about 1 in 7, 1 in 8. And the chance of getting prostate cancer in men is about 1 in 7 as well. So, you know, serious cancer, gram for gram, probably the most aggressive tumor out there, but it's fortunately not the most common tumor that we see. What causes it? Well, we know that there's irrefutable evidence that sun is probably the most important etiological factor in its development. But we also know that genetics plays a significant role in this disease. I'm going to harp on the genetics in a moment. We know that there are certain people who are prone to get melanoma. It is largely a tumor of Caucasian individuals. It's not to say that we don't see it in pigmented people of color. We've seen it in blacks. We've seen it in Asians, East Indians, First Nations people. So it's not unique to Caucasians, but the probability of people of color developing melanoma is significantly less. It's definitely less than 5% of melanomas will be of people of color in this country. In the States, it might be a little bit higher, but in this country, it's less than 5% of all the melanomas will be of people of color. So the people who get it are those who are red, blonde-haired, blue-eyed, fair-complected, those with freckles, lots of moles, people who don't tan very well and burn very easily. Those are all the risk factors. So what is a melanocyte? This cartoon just illustrates what is a melanocyte. It's a pigment-producing cell located in the top layer of our skin, and it's illustrated by this cell right here, this brown cell that's got these extensions that are called dendrites. So these are the pigment-producing cells that give us our skin color, and this is the cell of origin of melanoma. It's when those cells go bad, and it's generally triggered by sun exposure in the right setting because of these personal features, as well as to genetic features that make you prone to develop melanoma. So when a melanoma occurs, if it's limited to the top layer of that skin, that purple zone there, that's what we call melanoma in situ, and that's when we want to catch all melanomas, because at that stage, melanoma is 100% curable. As the tumor advances and becomes more aggressive, it acquires the capacity to invade into the skin proper, which then could involve making its way into blood vessels, and then once it gains access to blood vessels is when it's possible to spread to other sites, including lymph nodes and internal organs. So in terms of melanoma genetics, we know that melanoma does occur in families. Up to 10% of patients with melanoma will tell us that there's a family member with melanoma. And there are many reasons for why this occurs. Many times this is just chance alone, or it's because of shared sun exposure patterns. Your father was a farmer, you're a farmer, so it's no surprise that you're developing melanoma. We also know that genetics is also involved. And in terms of how important is genetics, it's thought that maybe 5% of melanomas are due to actually a genetic susceptibility. We've now identified specific mutations that increase one's probability of developing melanoma, and they're referred to as susceptibility genes. These are also known as oncogenes or tumor suppressor genes. There are certain genes that impart a very high risk for developing melanoma to the point of 80 to 100% probability of developing melanoma, to those that are intermediate to low risk, which have a significantly lower probability of ultimately developing melanoma. When we talk about germ cell mutations, I just want to stress this because you'll hear the word mutation often dropped in reference to melanoma. Germline mutations are those that are present in every one of your cells and the ones that you share and pass on to your offspring. The other term that we use to describe melanoma mutations is the word somatic mutations. And somatic mutations refers to mutations that occur within the cancer itself. These are not transmissible. These are that develop either spontaneously or in many patients as a consequence of sun exposure. And we know that the amount of sun will dictate, what type of cancer you get and what role the sun had in playing in the development of your melanoma. So that picture of that person who's got that nasty melanoma on his cheek here, this is lentigo malignant. We'll be talking about that in a moment. This is the type that's classically attributed to lifelong chronic sun exposure, and has a very unique pattern on histology under the microscope, but also a very unique pattern when we look at the DNA signature of the tumor. The more common tumor, superficial spreading melanoma, tends to be linked not with chronic sun exposure, but in fact with sunburns. And that's what we're trying to show here. This is intermittent sun exposure. It's not with chronic sun exposure. And then there are some melanomas that have, very little to do with sun exposure, particularly the foot. This would have a very unique DNA signature, which would be quite different than you'd see with that facial melanoma or that melanoma that was seen on this person's thigh, which was attributed to intermittent sun exposure. And then lastly, there are areas that get no sun at all, which would be the genital area or the oral mucosa. And melanoma in these locations obviously have a very unique genetic signature, very unique somatic mutation, but it has nothing to do with DNA. We know that melanoma has one of the highest numbers of mutations of all malignancies that are out there. This graph, published in 2013, just highlights that the tumor has more somatic mutations per megabases of DNA material than any other tumor, and this is due to sun. The mutations that are seen are in fact have a very telltale UV signature that tells us this is due to the sun. It's not due to some other carcinogen or some other environmental factor that's causing these mutations. Now, these mutations that occur result in literally hundreds, if not thousands, of abnormal genes, and scientists have segregated these abnormal genes into what's known as driver mutations as opposed to passenger mutations. So the driver mutations are those that we think progress and allow for the tumor to become a true malignancy, whereas the pathogens are just there for the ride. They're actually not the ones that are forcing the cancer to become more and more aggressive. The most characteristic of the tumor, and the one that's treatable, actionable, is BRAF mutation. There are other somatic mutations that occur that are listed here, but these are not necessarily actionable, so I just list them here, but we don't have necessarily treatments for all these other mutations that have been linked and are thought to be responsible for making tumor become more and more aggressive as these mutations accumulate. As I mentioned, this can be a family trait, and there are multiple genes. I'm just going to speed this up a little bit here. There are multiple genes that are linked with melanoma. Again, maybe 5% of melanomas are due to susceptibility genes that are imparted onto our offspring. The classic is this known as the familial atypical multiple mole melanoma syndrome. This is due to a defect called cyclin kinase 2A, and in this, it's common to have multiple family members with melanoma. Most people who develop melanoma have multiple nevi, hence the reason why it's called multiple mole syndrome. And it's for the most part linked just with melanoma. A subtype of this is also linked with pancreatic cancer. In fact, other cancers have been linked, but the cancer that's most strongly linked is pancreatic cancer. Another rare familial melanoma syndrome is known as the BAP1 tumor, and this is linked with kidney cancer, two types of lung cancer and mesothelioma, and ocular melanoma. These are the cancers that are linked with this type of cancer. These people also have lots of moles, but their moles look different. They're usually more red to flesh colored, and they're on histology under the microscope, they look very different than a regular nevus. So we're now going to focus on the subtypes of melanoma. So as I mentioned, melanoma presents as a changing mole or a new lesion. Sometimes melanoma can lack color, and that's when it challenges not only you, the public, but also us as physicians as to whether we're looking at a melanoma or not. One of the most important clues is change. Symptoms are often late changes, so we don't want people to be coming in because they have ulceration or crusting and scabbing. That's usually a sign of more advanced melanoma, so we actually don't want to see that. How melanoma presents is dictated by what subtype we're dealing with. There are 4 classic subtypes, and we'll go through them quickly. So the most common type is superficial spreading melanoma. This tends to occur in sun-exposed areas, and this is the one that shows the prototypical A, B, C, D, E features. The other type that we see is nodular, which unfortunately does not have those features. So this is a superficial spreading. I think all could appreciate. There's some worrisome features there. It's asymmetric. It's got color variation. This is very large. It's about 1.5 centimeters. And it's got irregular borders. So it's got all the warning signs. This one, although it's uniform in color, it does definitely have asymmetry, and it's got border irregularity with notching, which would then, again, warn you this is probably something sinister. Nodular melanoma is a major challenge for dermatologists to diagnose. Now, in this case, it was brown to black with this component of red, so it was multicolored, and it just looks like a lump. Nodular melanoma looks like a lump. It tends to occur in intermittently sun-exposed areas, primarily a trunk, but you could see it any part of the body. And here's an example where there is no color. It actually looks purple, and a primary care physician might even confuse this for a benign entity just because it doesn't have the black that we classically associate with melanoma. So a lot of nodular melanomas are actually blue, purple, red in color, but if they're black, it makes it a little more obvious. Lentigo maligna is the other subtype, third most common subtype, and this is the type that looks like a freckle when it initially appears, typically on chronic sun-exposed areas of the face and neck area. And then acanthosis is the type of melanoma that typically occurs on the soles, mucosa, and the nail units. So here's lentigo maligna at its earliest stages. You would be hard-pressed to fault someone for thinking that this was something sinister. I mean, with just visual inspection with your eyes, you would assume that that's a sunspot or a large freckle, and it's only over time that it starts to develop multicolors, as seen here, that you recognize, oh, this is probably something more. And invariably, though, a biopsy is required. You're not going to be able to diagnose just relying on clinical inspection. As time progresses, occasionally a growth will appear within it, and this is obviously a sign of a more advanced tumor. But all of this is melanoma. It's just not that red nodule that you see, that little red lump there. All of this is melanoma. So often, again, appears a large age spot or a sunspot, and then over time they develop a more thicker component. On the soles, they can similarly look very subtle. You may have a brown spot on your foot, and I mean, if you were to see this, you'd be hard-pressed to call that melanoma. This obviously was required a biopsy, and the only clue would have been change. But as time goes on, usually multiple colors come into play. It's got that asymmetry, border irregularity, multicolors, in this case very large. It's almost 2 centimeters. So all these warning signs would be a clue that you should be seeing someone. Here's a person that we had seen who had let this go on for about 10 years. Hopefully we don't see this too often, but it does happen. And we even see where they progressed to ulceration, which means someone had left this for a very, very long time. It does occur in the nails. When it occurs in the nails, it's very challenging for the dermatologist to recognize it as being melanoma. Color is not reliable, meaning just because it's very, very dark doesn't necessarily mean it's bad. Pigmented streaks are very common in people of color. People who are Black, East Indian, Asian, have a very high probability of developing these pigmented streaks in their nails, much less common in whites. Caucasians only have about a 1 or 2% probability of developing streaks in their nails. But it's over time, as they start to change, as you can see, the typical change is that they are broader at its base and taper as the pigmented streak works its way to the free end of the nail unit. And with prolonged time, you'll see extension of the pigment to the surrounding skin, as well as a growth appearing as seen here in this very advanced subungual melanoma. I've made it sound like it's easy to diagnose melanoma. In fact, it's not. This study just published a little over a year and a half ago from the group from Harvard recognized that, in fact, even for dermatologists, melanomas tend to fall into 5 categories. The classic melanoma, the top row here, where every dermatologist will be able to diagnose that on visual inspection alone. Unfortunately, there are melanomas that even to the best trained eye will look like a mole, and it'll be only on biopsy that you'll be able to sort that out. One of the biggest categories is melanomas that have no color, and they're often diagnosed as non-melanoma skin cancer or something else, and no one recognizes them for what they are. Occasionally, melanomas will look like age spots, like seborrheic keratosis, or, as we already mentioned, they can look like a sunspot known as a lentigo. In fact, there are subtypes of melanoma we call undiagnosable melanomas. The most prototypical is desmoplastic. It looks like a hard scar-like lump. It could occur any part of the body, but more commonly in sun-exposed areas. Again, these invariably are never diagnosed by the dermatologist. They're thought to be a scar, and it's only because of a biopsy are they recognized. An entity known as primary dermal melanoma has no color. Pigmented cells, the melanocytes, are located not in their usual location, and so even for the pathologist, they're a challenge to diagnose. But this is an entity that's become accepted over the last 10, 15 years, a primary dermal melanoma. There are melanomas that are just classically have no pigment, as seen here, or this type known as spitzoid melanoma. All these melanomas are, for the most part, undiagnosable and require, meaning with visual inspection alone, they require a biopsy to come to the conclusion. Now, how do we actually diagnose melanoma? It's based on biopsy. I've already alluded to that. And the preferred method of biopsy is a complete removal, and that's what we're trying to show here. We prefer a complete excision of the suspicious lesion if it's all practical. Now, that's not always feasible, and sometimes you'll have to choose a different strategy. So in this case, this was about a centimeter lesion. If the dermatologist or the family doctor isn't too pressed for time, this is the preferred method of removal. It ensures that all of the specimen is submitted. It gives us the most information in terms of what are we dealing with, and it will give us the most crucial information about thickness. That's vitally important to managing melanoma. Now, what if the spot is too large? Then there's a rule that we use, and that is if the lesion is the area that's most raised, the darkest portion, if there's an ulcer in the area, all those areas should be biopsied. If you think it's arising from a mole, or maybe a patient's told you, I've had this mole all my life, and then there's a kind of a part that's irregular, try to include both. That'll make it clear that part of it is a mole and that the other is the melanoma. And also we frequently entertain just doing multiple scouting biopsies for particularly large lesions. So here's a person who's got a very large brown spot, multicolored, that goes all the way up to here. And it's not possible to remove a lesion of that size without first confirming what you're dealing with. And so it's routine to do multiple scouting biopsies. So here we did multiple scouting biopsies just to the darkest area, this case just to see if the extent of it, is this very light brown stuff truly melanoma or something else, and this just to verify that's also melanoma as well. For a lesion like this, I mean, we could do multiple scouting biopsies, this brown spot, that brown spot, but most of the action is going to be the thickest part, so that's why we focus on that area that's raised. For a lesion like this, although the rule is to biopsy the thickest part, sometimes it's just not a desirable place to do that. Sometimes you just want to get a diagnosis, and taking it a little bit more towards the edge of the lesion will make it easier for you to close the hole that you've created. If you made it dead center, the tumor often is too mushy and will not close, and you'll be left with a big hole that no one's too happy with. An area like this is way too large to excise in its entirety. So again, just choose the darkest area, the area that's ulcerated, which I've shown you right there. That's a little scab. That's the area that's ulcerated. Now, when the biopsy is obtained, some important features are recorded and relayed to the doctor. And the most important feature that we rely on is how thick the tumor is and whether there's any break in the lining of the skin, also known as ulceration. The thinner the tumor, the greater the probability that nothing bad will come out of your tumor. And so for the most part, anything less than 1 millimeter is deemed a very early melanoma. Ulceration generally suggests a more aggressive tumor, and as this little schema here shows in this table, it can put you into a higher category just on that alone, even though it might be a thin tumor. If you have ulceration, that suggests a more aggressive tumor. In addition to those features that we see in the biopsy, when we stage people, we also want to know what's happening with their lymph nodes. And we'll talk about this in a moment in terms of how we actually address your lymph nodes. But initially it starts with just feeling, see if the lymph nodes are swollen, and then in the end, chasing down lymph nodes that we suspect might be harboring cancer cells through a technique called Sentinel lymph node biopsy. And then last, we look to see if there's actually an internal spread of your cancer. And when we talk about internal spread of this cancer, anything is possible. So when you take all those features together, what is the thickness? That's the T variable. N is what's happening with your lymph nodes, and what's happening with the internal organs. We put that all together, and it gives us what we refer to as the stage of your cancer. We also have this complicated table here that shows you that it's not very straightforward. You have to kind of put these various variables into place before you can actually appropriately stage patients. Once you stage the patient, the treatment of choice for this cancer, and has been for almost 120 years now, is surgery. Still to this day. And in terms of the surgery that we do, the surgery is dictated by what we see under the microscope, meaning how thick it is and whether it's ulcerated. That influences what degree of safety margin that we should be striving towards. And so we have these various margins that we aim for. For patients that we think are at risk for developing spread to lymph nodes, we will offer a staging sentinel lymph node biopsy. This has become all the more important with the most recent staging system. And I try to stress to patients when they come to see me is we are doing a sentinel lymph node biopsy for the most obvious and intuitive reason, to hope to find that it's negative. So even people with advanced melanomas, people with really thick tumors, 4 millimeters ulcerated, if their lymph nodes are proven to be clear based on a staging sentinel lymph node biopsy, we know their outlook is quite good. It's not a guarantee that everything's going to be well, but we know that the great majority of patients will outlive their melanoma. So it is vitally important that we offer this. Now, we only offer to people we think there's a significant probability of melanoma. For the most part in Canada, we do not offer it for melanoma if the melanoma is less than 1 millimeter. There are obviously exceptions to that, but that's for the most part a truism. And it's only after 1 millimeter do we consider a staging sentinel biopsy. It involves the use of various dyes that we place where your melanoma is or was, meaning if it's already been excised, it'll be in that proximity to the scar, and then we would allow these dyes to make their way to the lymph nodes, which guide us as to which lymph nodes we should be sampling. In terms of lymph node disease, I just want to highlight there's been a significant change in how we manage lymph nodes. In the past, if you had spread of your melanoma to your lymph nodes, it would entail, as had been the case for 50 to 100 years, to remove the remaining lymph nodes. And this paper from 2017 has essentially changed that entirely worldwide. We all do not offer removal of the lymph nodes if we find they're spread to your lymph nodes. Instead, we take a wait-and-see approach. This paper showed very nicely that taking a wait-and-see approach has no impact on your overall survival, as opposed to removing them preventatively at the very, very outset. So this is something that's almost now universally accepted here in Canada. With detection of spread to your lymph nodes has also been changed by recent advances in therapy. The most recent advances in therapy are on what we refer to as targeted therapies, when we discover actionable mutations in the tumor cells as well as the immune system. We restrict the use of adjuvant therapy for people with stage 3 disease, which is people with known spread to their lymph nodes. We also give it to patients with resected stage 4. So if you have had melanoma and coincidentally you were found to have spread to just one site in your lung, and we remove that, that will be then deemed as resected stage 4, and you'd be offered adjuvant therapy. I'm not going to go into detail here because I'm not an oncologist. It's just that we don't have a lot of time to cover all the therapies. Just to let you know, for those who want more detail, you can actually go to this website at nccn.org. It's open to the public. It's not limited to physicians. I'm actually accessing the physician portal, but you can access it as the public, and you can see what's being recommended for melanoma. Now, I'm conscious of what Natalie said. I could not cover all the therapies for melanoma, because that in itself is multiple lectures in itself. I am struck by how advanced this document has become. For most of my career, the melanoma document that was available on this website, nccn.org, was about 20, 30 pages. It's now 225 pages. And it's just a very, very complicated area now to talk about how we deal with people with stage 4 disease, how we deal with systemic therapies for adjuvant therapy, the role for radiation therapy, and the like. So we'll leave that for another day. Perhaps if you invite me again, we can cover that, or perhaps we can get an oncologist to cover those. So now I'm going to move on to non-melanoma skin cancer. The most common skin cancer that we're going to see is basal carcinoma. This counts for 80 to 90% of non-melanoma skin cancer. So when people use the word non-melanoma skin cancer, they're referring to two cancers in particular: basal cell carcinoma and squamous cell carcinoma. Now, other tumors like Merkel cell carcinoma, etc., could be encapsulated in the term non-melanoma skin cancer, but that's not what they're referring to. They're generally referring to basal cell carcinoma and squamous cell carcinoma. Now, this is a tumor of the basal cells, and we'll show you in a moment what is a basal cell. It's a cell of the top layer of the skin, or it could be a tumor of the hair follicles. This, in fact, is the most common malignancy that we see in Canada by far. It exceeds all other cancers combined, as Natalie had mentioned in her presentation. And it is a skin cancer that is related to chronic sun exposure. So it's in contrast to melanoma, which could be partly intermittent sun exposure, chronic sun exposure, very little sun exposure. This invariably is due to chronic sun exposure. We also know that genetics plays a role. There are actually genetic syndromes that make you prone to develop this malignancy, and they're listed there. And carcinogens can also be involved with their development, primarily radiation. So radiation that was given for, say, breast cancer. 20, 30 years later, you might develop a basal carcinoma as a consequence of that radiation that you received for your breast cancer. So basal cell are these bottom cells of the epidermis, hence the reason why they're called basal cells. And initially, they just form small little clusters, and as they become larger and larger, they start to form these other forms of clumping of tumorous cells, as you see here. How they appear is dependent on the type that we're looking at. They're generally a tumor of people over the age of 40. It is very unusual to see a basal carcinoma in someone under the age of 40. The classic types that we see are known as the nodular type, superficial, and pigmented. This is a classic nodular basal carcinoma, which fortunately we don't see very often. This photograph's actually a patient of mine almost 30 years ago. So fortunately, we don't see them like this very often, which is good. So this is a very large tumor that would have presented as a non-healing lump that over time had grown to form this persistent ulcer with a scab on the surface. More often, they present as, a shiny, bright red, pink to skin-colored growth. And one of the clues that dermatologists use is the fact that they have prominent blood vessels. Now, this one shows very nicely the prominent blood vessels, but often we need a magnifying lens or a dermatoscope to highlight that increase in blood vessels. This is another example that's not as protruding, and it's that classic ulcerative type where it's rather than growing outward, it's growing inward and resulting in a persistent, festering, non-healing growth on his nose. Fortunately, with advances in diagnostic tools, primarily dermatoscope, we are now diagnosing basal carcinomas that are very, very tiny and in the past were difficult to recognize for what they are. So here are people with very tiny, we're talking like 1 or 2 millimeter papules, but with the aid of dermatoscope, you should be able to easily diagnose these growths. Again, similar lesions that are very, very subtle. You barely see that little growth there, that little growth there, these little growths here, and it's with the aid of dermatoscope we're diagnosing them. So we are not seeing people like this very often, fortunately. So this is the classic nodular type. So this picture just shows what we see with our magnifying dermatoscope, this prominent blood vessel pattern. The other type that's very common, and it's very hard for family doctors to recognize, even patients, because they think they have ringworm or eczema or psoriasis. And so it looks like a scaly red patch. And that's invariably how the family doctor treats these, usually with a topical. And it's only after, increasing growth and failure to respond to a usual eczema cream or psoriasis cream that a referral is made and a biopsy is taken. For dermatologists, this should not be a confusing thing, but for family doctors, this is a major hurdle for them. They have a tough time recognizing this for what it is. And again, these pictures that I'm going to show you, they all look like psoriasis or eczema. The other subtype that's common is pigmented. It's not limited to people of color. It can be seen in Caucasians as well, where you start to see shades of brown, and then people start to wonder, could this be a melanoma? But again, with the aid of a dermatoscope, you should be able to recognize the prominent blood vessels. For those who are looking at this slide, they're probably wondering, what's the problem? It's this depression that you see right here. And this subtype, unfortunately uncommon subtype, is never recognized for what it is. So this is actually a sclerosing basal carcinoma, meaning a tumor that has significant scarring tissue, and it's not easily recognized that this is actually a tumor. It's only on biopsy do you actually recognize that it's a tumor. One of the things you'll often hear patients say is, it's only skin cancer, kind of implying that it's a nothing. Basal carcinomas are nothing. I mean, no one dies from it, which is true. Very few people die from basal carcinoma, unfortunately, and that it has no consequences. But you can see it actually can be an aggressive tumor. Here's a person who neglected this tumor. Most of the time it's due to neglect, but sometimes it's just due to the nature of the tumor itself, where it's very rapidly growing, very aggressive, and his ear was completely destroyed by his tumor. Another more advanced, basal carcinoma. So these can be, very advanced tumors. Now, fortunately, we don't, as I was showing with those tiny little nodular-based carcinomas, that is more and more the norm for at least a dermatologist. And a person like this should be a rare person. Here's a person where half their back is involved with a melanoma or basal carcinoma that's even invaded into the spine. Now, in terms of how we diagnose it, diagnosis can be therapeutic as well. So many of us will do a type of biopsy called a shave biopsy or curettage, which serves two purposes. One is provides tissue for a diagnosis, but also provides, a cure for the lesion. Surgery is the preferred method of dealing with it, and there are, again, many different strategies in terms of surgery. That includes this curettage, a scraping technique, the shaving off the cancer. You could formally cut it out, which we do frequently. And then there's a very detailed type of, very controlled type of excision called Mohs micrographic surgery that's appropriate. There are creams and lasers and likes that are used, but they're not used very frequently. They're used in very specific cases. Not to say that they're bad or not. They just have their very unique place, and this is not the forum for us to go through detail as to when we should be considering those other types. The ones I do want to highlight is that we now recognize that there are people who have, like that person who had lost his ear, locally advanced tumors that are unresectable, and that they are not amenable to the other alternative therapy, which is radiation therapy. Radiation therapy can be a very effective therapy for basal carcinoma with an excellent cosmetic result because there's no removal of tissue. But there are cases where you've gone too far and radiation will not work. That example of that person with that tumor on the neck, the individual on the back, neither of those would have been amenable to radiation therapy. And for most of our existence, we had no therapy. But fortunately, over the last 5-10 years, there are now therapies for locally advanced and basal carcinoma that's actually has spread. And these therapies are known as hedgehog inhibitors. The first to be approved and is available in Canada is known as Vismodegib. Is it a wonder drug? No, we wish it was, but it's not. But this picture shows for those who do respond, the effects can be dramatic. Here's a person who had an inoperable tumor that was not amenable to radiation because it was involving the bone of the skull, and he was placed on Vismodegib, and within 8 months, the tumor had regressed to the point that there's really nothing visible there. He's got a little open sore there, but there's no persistent tumor. Now, it's beyond the scope of this presentation to talk about Vismodegib and its role and its side effects and the likes, but it just shows you that this is not necessarily, game over when a patient presents like this, and we do have more advanced therapies. There's a second more advanced therapy out there. It's also a hedgehog inhibitor called Sonotagib, and it can have similar dramatic effects in terms of improving the tumor. This drug is approved in the States by the FDA and approved in Europe. Unfortunately, it was not approved in Canada. It was recently up for consideration, and it was not approved. I know that the Save Your Skin Foundation wrote a letter campaign to try to get the powers to be with Health Canada and PCODER to consider it as an alternative because we need more than just one option. And unfortunately, they rejected the submission, and right now it's still not available in Canada. It's available in Canada, but it's not officially being approved or paid for by the cancer agencies in Canada. This is disheartening to us because there is suggestions. I'm not going to say it's strong, but there are suggestions, and I use the word suggestion, to tell us that it might be a slightly superior product to the currently available drug. And so I'm hoping that Health Canada will revisit its stance, and PCODER will revisit its stance in terms of Sonotagib, because we need alternatives. We just can't be limited to just one drug. The next non-melanoma skin cancer is squamous cell carcinoma. This is the second most prevalent non-melanoma skin cancer. It accounts for about 10-20% of non-melanoma skin cancers. And this is a tumor of the prickle cells, or also known as spindle cells of the epidermis. Again, it's the second most common cancer that we'll see of all types of cancers. And it too is strongly linked with sun exposure. In fact, this tumor has one of the highest mutational burdens of all tumors when they look at that. So I mentioned melanoma, and that graph showed that, but they actually did not look at skin cancer of the squamous cell carcinoma type. In fact, squamous carcinoma even has a higher mutational burden. In terms of who gets this, I mean, it's people who are susceptible, and there are people who have genetic tendencies towards this, same as we see with Basal carcinoma. And then we also see people who are exposed to carcinogens. In this case, it could be chemical, not just X-ray. And then people who have immunosuppression, chronic infections, primarily the human papilloma virus, the virus that causes warts. So this is the prickle cell. So the deeper blue cell of the top layer of the skin is that basal cell. These cells are known as the prickle cells or the spindle cell, or the spindle cells. These are the cells that are responsible for the squamous carcinoma. And so when these cells go bad, again from sun exposure, they'll form a growth. If that growth is limited to the top layer of the skin, we'll use this term called squamous cell carcinoma in situ, or sometimes you'll hear the terms called precancerous growth. So as long as it's in the top layer of the skin, often we will refer to these as precancers. They're not true cancers. It's only when they invade into the skin proper, where there's access to potential blood vessels, do we use the word invasive squamous cell carcinoma. These typically occur in chronically sun-exposed areas, so head and neck area, particularly the face, nose, lip, dorsal hand, the back of your hands, your forearms are common sites. You'll often see evidence of chronic sun damage. Now, when these appear, they often appear as one of the classic precancerous lesions, and it's only over time do they become obvious that they're actually squamous carcinoma. So I'm actually going to start this presentation with the precancerous growths, also known as the pre-malignant lesions. The most prototypical is the actinic keratosis. Now, we don't know what percentage of precancerous lesions become invasive squamous cell carcinoma. The percentage is definitely less than 1%. And fortunately, these can be readily treated with other modalities rather than simple surgery that we use for squamous carcinoma. These can be treated with creams, with a liquid nitrogen, with laser devices, etc. So these actinic keratosis generally present as seen here as scaly, rough spots that can be skin colored or pink to red in color. Here's a person who's got lots of sun damage, and often the best way to perceive these is just by running your finger over your forehead or your face in general, and you'll notice, hey, why do I have a little rough spot here? And so he'll be rubbing his finger over his forehead here, and notice that that spot feels rough. This one's obvious, but that one would not be so obvious. As time progresses, they become thicker. Thicker rays does not necessarily mean that they become squamous carcinoma yet they could easily be confused for a squamous carcinoma. It's when they're actually infiltrating into the skin proper where you start to feel firmness in the deeper components. Did you recognize that it's actually a squamous cell carcinoma? Same with this picture here. It's growing outward. It's forming a growth called a cutaneous horn, but it's still not squamous carcinoma. It's still at the pre-cancer stage, the squamous carcinoma in situ. Similar changes occur on the lip. In that setting, we actually use a different term called actinic keratosis, but it looks very similar. Although to the lay person, it may look simple as just chapped lips. I just have chronically chapped lips. But when you feel it, you'll notice that it feels constantly rough. They're frequently breaking down, have little fissures, cracks, bleeding. And so through a biopsy, you recognize, in fact, no, that's sun-damaged precancerous skin. The other precancerous skin lesion is known as Bowen's disease. And it looks very much like the lesion we've shown earlier, the squamous carcinoma, the basal carcinoma of the superficial type. This looks like a non-healing eczema, psoriasis, maybe fungal infection, ringworm. So often it'll be that, but the clues will be that it's in a sun-exposed area, it's slowly enlarging, they're usually just solitary, they're not multiple, whereas a person with eczema or psoriasis generally would have multiple sites. Another lesion that could easily be fooled for psoriasis, but through a biopsy, it can be appreciated that this is squamous carcinoma in situ, as is this lesion here. Now, when do they become squamous carcinoma? When you see that it's hard in the sense that the base is hard, not the surface. So this horn would have a hard root, like we showed of that lesion of the ear, but it's the base of the skin proper. You notice that it's hard, that it's forming an ulcer, as you see here, or that it's becoming very inflamed. All those are the tip-offs that this is not a precancerous squamous carcinoma in situ, but it's becoming an invasive malignancy. Here's an inflamed lesion that it doesn't have all the other telltale signs. It's not particularly scaly. It's not ulcerated, but it's definitely red, and it'd be hard. Here's another one that's invading the ear, and you can see it's becoming very, use the term infiltrative into the skin proper. That would be very hard. That part you'd be palpating there would be very, very hard. So it does occur in other sites and becomes more aggressive, as you see here in the lip. Cousin entity I just want to highlight, because it does occur, is keratoacanthoma. This is an entity that's now kind of uncertain as to where it fits in the big scheme of things. Historically, it was viewed as a low-risk malignancy or even a benign entity because they could self-regress. But pathologists now are very reluctant to use the word keratoacanthoma, and it's very unlikely you'll get a pathology report that says that. Invariably, they'll be called a squamous cell carcinoma of the keratoacanthoma type. What separates this is that it appears as such here, just like you saw that lesion on that temple, very rapidly growing, bright red growth that forms a crater in the center. It peaks at about 8-12 weeks and then starts to disappear. So it's a person that we had seen, and you can see the lesion was starting to regress, and if you waited long enough, the lesion would completely regress. But most of us are reluctant to do that, and so invariably they're removed, and they end up being called a squamous carcinoma of the Ka type. As I mentioned with basal carcinoma, there's this perception by the public, oh, it's just skin cancer, it's of no consequence. It's not true. This is a more aggressive tumor than basal carcinoma and can be potentially life-threatening. Here's a person who's allowed their tumor to become not only very large, but it's now involving the tendons of the back of their wrist. So here's a very advanced, locally advanced squamous carcinoma. Here's a person with a more advanced squamous carcinoma of the scalp that's involving the bone of the scalp. And when this usually occurs, these are unresectable. They're not amenable to the usual therapies, including radiation therapy, and they were often a fatal consequence of the disease. Here's a person who's actually developed spread of their cancer. So the other two were called locally advanced. There's a person who developed spread to their lymph nodes. Now, again, it's beyond the scope of this presentation to go into detail about squamous carcinoma. Just to let you know, this is highlighted, and the treatment of choice is surgery if it's doable. When it's at the pre-cancer stage, we have all these options. In fact, the preferred is liquid nitrogen, but you have various topicals that are available in Canada, including Epidiolex and Micomod. We also have laser devices. And then there are various forms of surgery, from this curettage, shaving, formal excision, and then Mohs micrographic surgery. Those aren't appropriate. Our radiotherapy is a very reasonable approach. And then for more advanced tumor, up until recently we had no effective therapy, but recently, 2-3 years ago, it was approved that we have a form of immunotherapy called cemiplimab that's available to us that would be potentially effective on a person like this or like this, where surgery or RT would not be effective. And so the study that was the one that led to the approval of this drug is this paper here that was published in the New England Journal of Medicine a few years ago. So we have about 10 minutes left in the presentation. I still have Merkel cell carcinoma to cover. Do people want to hear about Merkel cell carcinoma? It's about 15-20 minutes, or we can leave it for another day. I'm happy to come back for another session. I'll let Natalie call the shots. So Natalie, putting you on the spot.
Well, thank you, Dr. Salopek, and I'm just blown away by your presentation. It's been amazing. I've learned several new things, and you have returned the favor of a large agenda. I definitely have work to do to update our website and resources, thanks to you. So that's great. I appreciate, yes, for the sake of time, why don't we hang on to Merkel cell carcinoma? We do have a previous webinar that we did on Merkel cell, and I can include that in the follow-up emails and links, as well as treatment for advanced melanoma. So I'm happy to include those and send those in our follow-ups. Is there anything else you'd like to cover, Dr. Salopek?
Actually, we can just talk about sun exposure then. So,
okay,
you gave me a very ambitious agenda.
You have blown it out of the water. It's great. Thank you.
So, I thought I would actually not make formal slides for sun awareness, but we can talk about it. We can just open up the questions, and I can talk about sun protection. As you've heard, I've hammered it over and over again. Squamous carcinoma, basal carcinoma is a sun-induced malignancy. Melanoma is a sun-induced malignancy. Merkel cell carcinoma is a malignancy that's dependent on both sun and a virus. So that is a unique malignancy. And interesting, there's a very big difference in terms of the role for sun in this tumor based on where you live. So in North America and Europe, 80% of Merkel cell carcinoma is due to the virus, and the other 20% cannot be attributed to the virus, meaning they cannot detect the virus, and it's blamed on strictly the recently detected virus, or it's due to sun in those 20%. Whereas in Australia, it's the opposite. 80% of the malignancies of Merkel cell carcinoma that occur in Australia are due to sun, and only 20% can identify the virus. So it's very interesting that there's that very big difference. But again, Australia is a country with lots of sun. So it just stresses the importance of being, and I use the word prudent about sun exposure. I had a mentor who trained me in New York, and he almost put the fear of God in patients when it came to the sun. I'm not sure if that's the best strategy to live a nice life. I mean, we need to enjoy the outdoors. The good Lord has given us a very nice world to explore and to see, and we can't live under a rock. So I think we need to just be wise about sun exposure, and there's tons of strategies to safeguard against excessive sun exposure. The easiest is to time your activities and your outdoor adventures to when the sun is not at its peak hours, and you're least likely to have any significant damage from the sun. So in North America, or at least I say North America, in Canada, for the most part, if you do your activities before 10, 11 o'clock, so if you did your round of golf before 11 o'clock, you generally don't have to be so conscious about the sun. You generally don't even need sunscreens at those hours. Similarly, if you time your activities to after 5 p.m., you don't have to rely on, strategies to protect yourself from the sun. Now, if that's not in the cards, if you can't, limit your activities to off-peak hours of sunlight, then your best strategy, in fact, is to keep your clothes on. Now we all say, it's Toronto, it's 37 degrees, it's high humidity, that's impossible. Well, it's not the most pleasant thing, but there are now lots and lots of clothing lines that are out there that are geared just for that scenario, where they're comfortable to wear, and yet they will protect you better than relying on a sunscreen. So the second line of defense is protective clothing. That includes a hat. We do recommend glasses or sunglasses to protect your eyes. We'll leave that for another day, but we also want you to protect your eyes because that develops cataracts and other problems. And then protective clothing. There are excellent long sleeve shirts out there that breathe well, that are very comfortable, and have what's referred to as UHF as opposed to SPF. So we have SPF, which is sun protection factor, and U stands for ultraviolet light protection factor, and that's in reference to clothing. So UHF is a clothing specific rating of how protective it is for you, as opposed to FPF, which is a chemical measure of how much it protects you from the sun. The next strategy that we recommend is sunscreens, and in sunscreens there are lots of sunscreens to choose from. The sponsor of today's session makes a great sunscreen, as do a lot of other companies. A lot of the sunscreens, if not all of the sunscreens in Canada, have the Canadian Dermatology Association sign of approval, meaning they are viewed as broad spectrum sunscreens. They protect both UVA and UVB, that they are acceptable to the user. With sunscreens, we have so many different sunscreens to rely on. We have sprays, which are very useful when you're trying to cover large swaths of body area like your legs, your back, etc. We have foams, we have creams. So all those are available to us. There's really no reason for why you cannot find a sunscreen that is agreeable with you. We do, recognize that there are two main types of sunscreens. Sunscreens is the generic term, or at least has become this generic term, but historically they were broken down into what's known as chemical sunscreens and physical sunscreens. Physical sunscreens are chemicals that they're inert, they're not absorbed by the body, and they filter out ultraviolet light. They do not allow the ultraviolet light to penetrate to the skin surface. Whereas chemical sunscreens, and there are many, those work by filtering the ultraviolet light, so it doesn't have the ability to, but it still penetrates, but it's less. And so your better bet, the more safer products are the physical sunblocks. Unfortunately, there aren't a lot of products that are out there just solely physical sunblocks. There are many of the Neutrogena products, the Umbrella products, etc. I'm just listing some brand names, have physical components to them. And the two components are zinc oxide and titanium dioxide, but most have chemicals. There's only one or two products that are just strictly physical. Now, you may ask, why do we use physicals? Because they have no chemicals that you can react to. Chemical sunscreens have the potential for you to react to. There's molecules within that you can have an allergic reaction to or a photoallergic reaction to. So they can be sometimes problematic for some people, but for the most part, they're safe and they don't have that issue. A very small subset, probably only 1 or 2% of the population, have those tendencies. Whereas physical, that will not be an issue. So I'm going to stop there, and I'm more than willing to take any questions from the chat box.
Wonderful. Okay, thank you very much. Again, Dr. Salopek, that's a very good overview of so many different kinds of skin cancer and facets to that. So I do have a couple of quick questions, or we'll see if they're quick. Someone asked if they have had an ugly mole removed in the past, which was benign. Should they then pay attention to the scar site? Can it become cancer afterward?
The answer is no. So ugliness is not necessarily an indicator of a bad growth. There are a lot of moles that look ugly from day one. Birthmarks often look ugly, and so just because they look ugly, not only figuratively but also literally, doesn't necessarily they're bad. And so the most reassuring thing is that it was interpreted under the microscope, and the pathology came back that it was a benign lesion. So if it's a benign lesion, it should never come back. The only caveat is there that sometimes pathologists make a mistake, and they say something is benign, and then over time it comes back. Now, that's a very rare event. I mean, that's not something that is frequent with pathologists. It's a very, very uncommon event that a pathologist makes a misdiagnosis, but it does occur. So I would not worry.
Okay, that's good. Good news. Thank you. Okay, if someone is currently on, now they've put chemotherapy in their question, but I would almost want to expand this if it's not too much trouble. If someone is on chemotherapy or immunotherapy or targeted therapy, would that prevent a melanoma or skin cancer?
That's a good question. I was just chatting with my oncologist about that. So the thinking is no, that it would not safeguard against you developing another melanoma. So it doesn't mean now you can be laissez-faire about sun exposure and that you don't have to see a dermatologist to have your skin scrutinized periodically. So many of the patients who are on immunotherapy still need to have their skin scrutinized by a dermatologist. Now that said, we had a case that was of a gentleman who was just sprouting melanomas left and right. And it was getting to the point that it was unmanageable. He actually developed metastasis from one of these melanomas because they were becoming more and more aggressive. And he was getting them like yearly. And at the time we ultimately put him on immunotherapy, he had about 10. And then we gave him immunotherapy to deal with the metastatic disease that he had to his lymph nodes. And interesting enough, he's never had another melanoma since. In 3 years, he's never had another melanoma. So it just piqued my interest. Maybe for people who've had multiple melanomas, giving immunotherapy somehow changes something in you that maybe makes your immune system more vigilant. It's known as immunosurveillance for malignancy, and maybe it could safeguard against malignancy. But we really don't know. We know with the other drugs that we use for cancer, not just the immunotherapy, targeted therapy would not prevent future malignancies. Neither would the hedgehog inhibitors. We've actually seen people developing other basal carcinomas on hedgehog inhibitors that they received for their basal carcinoma. So those would not. But the most tantalizing suggestion might be with immunotherapy. And in time, we'll see if it is or it isn't an issue.
Okay, that's interesting. Very interesting. Thank you. Okay, to be respectful of time, there are a bunch of questions, but I'll just ask one more, and then the rest we'll address via email with your help, if you don't mind, Dr. Salopek. But how often would you say a patient should be seen by their dermatologist after having a stage 1B melanoma removed and sentinel lymph node biopsy? How often? What's the follow-up or guideline procedure for
So,
that?
simple answer is there's no consensus. And it's very site dependent and even country dependent. It's manpower resource dependent. So I presume this person had a negative sentinel lymph node because that's what we call stage B. If you are stage 1B and your lymph nodes are negative, that's what we call pathologic stage 1B. And we know that person actually has got a superb outlook. So I used to watch those people very closely. I used to put them in the same category as everyone else who had melanoma that was eligible for a sentinel node biopsy, meaning every 4 months, and did that for a couple of years. And that's common to other jurisdictions. Australia that would have done the same. NCC and the States would recommend very similar. And then, start to stretch the intervals out to every 6 months, then maybe to yearly. What we've decided here locally is that those people do so well that we could be a little bit, hands off. And we see people just every 6 months for the first couple of years, and then thereafter once a year to the 5-year anniversary. And at that point, we'll decide based on other variables whether we should continue follow after 5 years or we should just let them go. With people with stage 1A, we are definitely graduating after 5 years. That's something that we're doing here at the University of Alberta, and more people are recognized, and that's a reasonable strategy just because there's only so many manpower hours available to us. And although it's been argued that the potential for getting melanoma is lifelong, you could get a second melanoma lifelong. It's just that we don't have the people to see people for the rest of their lives. So you have to kind of balance that. There will be a point. It's been calculated that if I was to see all my melanoma follow-ups after about 5 years, I wouldn't be able to see a new one.
Oh, no doubt.
Okay, no so doubt. Is that fair to the new person?
No,
I don't think that's fair to the new person that they should never see me again, or they should never see me or the people who specialize in melanoma. So you have to kind of draw a line as to when is it reasonable to just cut people loose, and we feel that 5 years is reasonable to let people go with strong education and knowing that you're always welcome to come back. It's not like you can't come back. Through the scan rule, with you participating and looking at your own skin, applying the ABCD rule, the ugly duckling, you'll probably find that next melanoma or next basal carcinoma before I will.
Yep, that's a good point. No, there are a lot of good tools out there now, and yeah.
There's also fair. Those who want to buy devices. There's tons of devices. There's apps out there. The apps are still rudimentary, but they kind of motivate you to, I got to check my skin. I forgot I got to check my skin. That kind of thing. And they'll have references as to what should be, worrisome. They even have apps that allow you to take a picture and forward it to somebody. And some expert on the other end of that app will give you advice as to whether you should be, being seen. So, I don't want the person who asked the question to think that, we aren't concerned about people. But again, there's a point where you have to say, well, you're over this.
Yeah.
You don't have to worry about your cancer anymore.
That's a positive outlook as well. And as long as patients know they have the right to ask for another exam down the road, should they, feel something suspicious, then that's the most important thing.
Pick up the phone and call me. You'll get in.
Wonderful.
I'll just say I want to see him again, and you'll get in.
Well, that's great. Well, thank you so much. As I mentioned, we have a bunch more questions, but we'll follow up by email. I just wanted to mention too, Dr. Salopek, thank you very much for bringing up the NCCN guidelines. We have quite a few of them listed. We have all the skin cancer related ones on our website, and you've brought a good point to the table. I'm going to include that in our follow-up email as well, so that people can go look at the guidelines for each of the individual indications if they wish to learn more. And of course, they can always email us, and we'll follow up accordingly. So
I never
that's
tried the
wonderful.
patient side. Have you tried it? Do you have to register? Like a physician, we have to register and show what, that we're legit and we actually work
Yes.
somewhere.
Yeah,
Because it's
exactly.
a little bit more detailed. I'm sure the physician side is more
It
detailed.
is.
We
Well,
actually
and
have to register it. I don't know if you have to
you
register as
do.
a patient though.
No, you don't. The patient ones are like open ebooks, and they're very easy to read, and there's quite a bit of thought put into the design, so it's easy for a layperson to understand. I will admit too, I have registered on the clinical side and seen the clinical guidelines as well. And I won't tell you how I snuck in there. I don't have a medical degree, but it is possible for people to do that as well. Though of course I don't recommend that. But we'll send the patient guidelines, which are quite easy to read and follow, and um, obviously give a lot of information that's relevant in Canada, even though they're developed in the States. It's great. So I
Well, we
will
use it
share
as
those.
a reference too. I mean, it's the backbone for almost every guideline in the world.
I
So,
agree. Agreed.
because they're so comprehensive. For those
Yes.
who don't know, I'm going to give a plug for the Melanoma Network of Canada. They put together a incredible booklet for melanoma for those who have melanoma. They don't have one for basal yet, or Merkel cell, but I know they're working on a basal one. But their
Okay.
melanoma booklet is incredible. So,
Yeah,
and
there
we
are.
pass it out to everyone. I'm sure you have
That's
the
right.
link.
Yep, there are a lot of great resources out there, so we will be sure to keep sharing those and that. Well, thank you again very much for your presentation, your insights, your expertise, and your time in preparation for this session, as well as the time we spent today. And I will follow up with you via email with a couple questions, and thank you again very much.
Right.
I'll mention again, this has been recorded and will be available on our YouTube channel and website in the next day or so, and everyone will get an email, and I'll send it to you as well, Dr. Salopek, in case you wish to share it with any of your network. So
All right. Thank you very much.
thank you so much for your time, and I will chat with you soon.
Bye bye.
Thank you. Bye-bye.